Hello and namaste everyone, and welcome again in third B&B knee course pre-course online discussion. I am Dr. Bibek Basugala from Tulihel Hospital, and today my moderators are Dr. Ishwar Pradhan from B&B Hospital and Dr. Sailas Ranjitkar from Norvik International Hospital. Today I will be talking on signs of ligament injury in X-ray, what we are missing. Plain X-ray is one of the most commonly prescribed investigation by the orthopedic surgeon, and I must say this investigation modality may be the one of the most underrated investigation modality in our practice. Most commonly, the findings in plain X-rays are obvious and diagnosis is straightforward, but sometimes the findings may be very subtle and we might be ignoring these very subtle findings. These findings may be of that of fractures, the avulsion fractures of muscles and ligaments, the indirect findings of musculotendinous injuries, and indirect findings of the ligamentous injuries. We orthopedic surgeons are used to seeing this type of very severe grade of bony injuries, and we are fascinated with fixing these fractures with various type of hardwares. But while doing this, we may be missing these type of very subtle findings in knee x-ray. These are usually missed because these are usually acutely injured patients and they are first seen by emergency care physician or the inexperienced residents or the younger doctors who have very less knowledge about the existence of these type of injury. So they are either missed, or even if they are diagnosed, they are considered to be of very less clinical significance and left as it is, thus leading to long-term morbidity. There has been proposition of various rules for prescription of knee radiographs. Out of them, Ottawa Knee Rule and Pittsburgh Decision Rule are the very famous one. The Ottawa Knee Rule suggests to have X-ray done only if one of the following is present, like age is more than 55 years, if there is tenderness at the head of fibula, if there is isolated tenderness of the patella, and if there is inability to flex at 90 degree, and if there is inability to bear weight in emergency department. Pittsburgh Decision Rule advises for the knee x-ray only if one of the following is present: if the mechanism is blunt trauma or fall, if the age is less than 12 years or more than 50 years, and if there is inability to bear weight in emergency department. There has been many studies comparing Ottawa Knee Rule and Pittsburgh Decision Rule, and all of them agrees that both of these rules are very sensitive in determining the optimal prescription of X-ray, whereas Pittsburgh Decision Rule is more specific than Ottawa Knee Rule in determining the uh, in ruling out the negative X-ray. There was good discussion about feasibility of use of these rules in Nepalese clinical practice during first ASON masterclass in Kathmandu, and all of the panelists were with the conclusion that these rules are not feasible to be used in today's medical field in Nepal, and the X-ray of knee should be guided by the clinical evaluation of the treating physician. The key sites to see in acute knee X-rays are multiple, and various anatomical landmarks, both bony and soft tissue landmarks, should be kept in mind before seeing the knee X-ray. Before reading X-ray, the X-ray should have some prerequisites, like we should have good true AP and lateral view, and if possible we should have the oblique views and the skyline views. The image quality should be very good, and we should always discard bad image quality because these subtle findings are easily missed with bad quality images. There are various direct and indirect signs in knee radiograph that leads to the diagnosis. One of them is lipohemarthrosis. Lipohemarthrosis means the collection of blood and the fats in the joint. This occurs because of intra-articular fracture and occurs within 3 hours of injury. The lipid or the fat being less dense floats over the surface, and usually there is formation of three distinct fluid layers, the upper one being the layer of fat, the middle one being layer of serum, and lowest one being the layer of sedimented cells. So lipohemarthrosis always points towards the presence of the intra-articular fracture. How subtle that. This is MRI confirmation of the same finding. The formation of three fluid layer, the uppermost being the fat layer, middle one being the layer of serum, and lowest one being the layer of sedimented cells. Sometimes there may not be lipohemarthrosis, there may be only hemarthrosis. This occurs when there is no intra-articular fracture but injury to the vascular structures inside the knee joint. So what we find in lateral knee radiograph is the dense shadow in the suprapatellar pouch. Sometimes both lipohemarthrosis and hemarthrosis may not be there in knee radiographs, and there may be only the collection, the serous fluid collection. In this case, there will be no three fluid layer and no dense collection within the suprapatellar pouch. Rather, there will be obliteration of normal soft tissue planes that is seen in normal knee radiographs. So after the indirect signs, there may be various direct signs of avulsion fractures in knee radiograph. And avulsion fractures can occur because of the ligamentous avulsion or because of the avulsion with the muscle pull. So most commonly seen avulsion fracture is the ACL avulsion fracture and PCL avulsion fractures. These cruciate avulsion fractures usually occur at the tibial insertion, and this picture shows the ACL avulsion fracture, which may be sometimes very subtle that we may miss this injury. Sometimes we even have to see the tonal views, and in tonal views the avulsion fracture may be displaced into the notch. Another cruciate avulsion fracture is the PCL avulsion fracture, and this avulsion fracture occurs at the posterior aspect of the tibia and extends way down the intra-articular surface. Another very interesting and historical avulsion fracture is the Segond fracture, first described in 1879 by Paul Segond, and it is the etiology of this avulsion fracture is controversial. There has been various etiology proposed for the Segond fracture. Some say this is because of avulsion fracture of lateral capsular ligament. Some say it is because of avulsion fracture of deep fibers of llio-tibial band. Nowadays, it is considered to be the avulsion fracture of anterolateral ligament, a new ligament in the knee. This is MRI pictures showing the same avulsion fracture because of avulsion of anterolateral ligament. The lateral sided signs are the lateral femoral condyle notch sign. Usually the lateral femoral condyle is divided into anterior and posterior half by the notch, which is normally up to 0.45 millimeter deep. But when there is anterior cruciate ligament injury because of anterior subluxation of the tibia, uh, the lateral tibial plateau hits into the lateral femoral condyle, thus leading to condyle fracture. So if there is increase in depth of this notch more than 1.2 millimeter, then it is considered to be significant lateral femoral condyle notch sign, and it is indirect evidence of the ACL injury. And in MRI we can see the marrow edema at the lateral femoral condylar notch, and the same case had full thickness tear of the anterior cruciate ligament. So this sign is the indirect evidence of the presence of ACL injury. Another sign is arcuate complex avulsion fracture. Arcuate complex consists of lateral collateral ligament, femoral biceps femoris tendon, popliteal muscles and its tendon, oblique popliteal ligament tendon, and arcuate ligament tendon, favulofibular ligament, and lateral gastrocnemius muscle. So these all combines to form the arcuate ligament, which inserts at the tip of the fibula. So when there is avulsion fracture of this arcuate ligament, there is small avulsion fracture at the styloid process of the fibular head. So another avulsion fracture that can occur in the acute knee radiograph is popliteus tendon avulsion, and that can be seen at the popliteal hiatus. Iliotibial band can lead to avulsion fracture at its tibial insertion, and usually this is just anterior and lateral to the Gerdy's tubercle, and it is usually more obvious in oblique radiographs. Medial side of the knee also can have avulsion fractures like medial collateral ligament femoral avulsion fracture. This is also called Stieda lesion, and this is because of avulsion fracture of femoral attachment of the medial collateral ligament. When these Stieda lesions are calcified, then it is called Pellegrini-Stieda lesion. There may be avulsion fracture of deep MCL from femoral side, or there may be avulsion of deep MCL fibers from the tibial side, which is the mirror image of original Segond fracture. Thus they are also called reverse Segond fracture, and reverse Segond fracture is usually associated with PCL injury and medial meniscus injury. So whenever we see the reverse Segond fracture, we have to always search for other ligamentous injuries. Sometimes there may be semi-membranous tendon avulsion fracture, and it usually occurs at the posteromedial corner of the tibia. There are various patellar signs that can be seen in the acute knee radiograph, and usually we require the skyline view and the lateral view at 30 degree of knee flexion. In skyline view, these are various landmarks. We can see the femoral trochlea and patella. In patella we can see the medial and lateral facets, and lateral knee radiograph at 30 degree flexion with both femoral condyles overlapped and fibula lying posterior to tibia is the ideal lateral knee radiograph for patella. And to see the alignment of patella, we have various ratios defined like Insel-Salvati ratio and modified Insel-Salvati ratio. The patella alta occurs when there is no support inferiorly to the patella, that is, if there is tear of the patellar tendon. So it is indirect sign of injury to the patellar tendon, and we should always look for this sign in acute setting. Sometimes there may be avulsion fracture from the tibial tuberosity because of patellar tendon avulsion. Sometimes there may be patella baja because of injury to the quadriceps tendon, the patella lying inferiorly than its usual position. Another sign in X-ray which we must look is the patellar medial avulsion fracture sign because of avulsion fracture of medial patellofemoral ligament, and it is usually most obvious in the skyline view. This occurs because of dislocation of patella, wherein the medial patellofemoral ligament avulses the medial side of the patella. There may be multiple avulsions in the same knee, and we should be very careful to look for avulsion fractures in the take-home message. X-rays may be very informative if given the meticulous attention. So let's start to see X-ray of knee joint differently from now onwards. Thank you. Let's hope this genius wraps up his career with the World Cup this time. Thank you.